Welcome to our first Health Matters, hosted by HSHS St. John's Foundation. Thank you for being here. I just wanted to my name is Caitlin Puckwick-Baker. I'm the annual gift officer at the foundation. I wanted to give a little update of who we are as the foundation. So a little bit about us. We were established to safeguard the mission of the hospital and carry forward the values and traditions that the sisters created. We seek and secure charitable gifts in support of St. John's Hospital, the Children's Hospital, and College of Nursing. These gifts help provide financial support for so many things, such as patient care equipment, continued education, the list can go on and on. And then just a little fact about the foundation, fiscal year 2020, we awarded a little over $2 million in support of patient care programs and equipment and student scholarships. So next up, you will be introduced to Chris Maurer, FLC member, as she introduces Dr. Marc Shelton, and we'll get on with the program.
Okay. Good afternoon. It's my privilege to introduce Dr. Shelton. Many of you probably know him as a cardiologist in the community, but for those of you who don't know a lot about Dr. Shelton's background, I'm going to give you a little bit of his bio. Dr. Shelton has been the Hospital Sisters Health System Senior Vice President and Chief Clinical Officer since April 2019. Dr. Shelton earned his medical degree from Vanderbilt University in 1984 and stayed for an internal medicine residency through 1987. He then became a cardiology fellow and was subsequently on the cardiology faculty of Washington University in St. Louis. He finished as assistant professor and co-director of interventional cardiology before moving to Springfield, Illinois in 1994 to join Prairie Cardiovascular as a partner. Following a decade of busy interventional practice at Prairie Cardiovascular, Dr. Shelton added administrative duties to his clinical practice, and he became the president of Prairie in 2009. As Prairie's president, he oversaw a tremendous expansion of the practice from a group of 44 cardiologists to a group of over 120 providers spread over the entire central and southern Illinois regions, providing service to 52 communities and 4 main hub hospitals. He has extensive research experience as well and has 37 publications in peer-reviewed literature. He has given lectures in 11 different countries and is a past governor of the American College of Cardiology. He was also appointed as a fellow of the European College of Cardiology in 2008. He has been on many international guideline panels and was the co-chair of the ACC Master Clinician Sessions for 4 years. He has been a guest editor for several cardiovascular publications and a cardiology board question reviewer as well. And at this time, I would like to turn it over to Dr. Shelton. Thank you, Dr. Shelton.
Well, thank you very much. I think that's what you get when you let your mother write your bio, huh? It's hard to joke on Zoom, but if you know me, I'm fairly lighthearted and informal. So what I said that I would be happy to do is do a little bit of background about the coronavirus pandemic, and then we can branch out and answer some questions, because there's really, as you all well know, a tremendous amount of good going on. Still quite a few hurdles to get over, but at least we're starting to, thank goodness, see the light at the end of the tunnel. It's been quite a really 10 or 11 months. I think we'll all have to agree. You know, when we talk about COVID, coronavirus, coronavirus, it goes all the way back. Coronaviruses have been around as long as we know, different ones, and they've had different mutations, and the coronavirus is one of the causes of the common cold in the past. And what happened this last, I guess 15, 16 months ago in Wuhan, China, it appears that an endemic coronavirus strain, the virus mutated into a form that was able to jump from bats into humans in the live market there in Wuhan. And then unlike previous coronaviruses, which typically were rarely deadly and rarely, hard to control, this was really a much more of a critical situation. And as you all well know, jumped then out of China and initially was a disease that was serious in people who traveled a lot, and then as it got into communities,
kids that aren't yet 3.
oh, let's see, if somebody would go on mute, that would be awesome. So now to the point where it's in all the communities in the United States, unfortunately, and community spread continues to be a significant problem. So that's kind of how it came up, and what is different about this coronavirus this last year and a half, and other ones. And first of all, and I'll kind of reference everybody's mindset to a comparison to influenza, because we typically deal with influenza every winter season in the United States, and people have a pretty good frame of reference from influenza. So when it started, there was a lot of wishful thinking, although the early data belied this. It was just overshadowed by other situations. And when it started, we were hoping it would be more like influenza. But unfortunately, there are 5 main factors about COVID-19 that have made this turn into the tremendously challenging issue we've been dealing with in the United States. One is that it's more infectious than influenza, at least twice, if not more. And with the new mutation, the H1117 that came out of probably London, potentially South Africa, it doesn't matter, it's already in the United States and spreading. It's even more infectious. So COVID is more, these variants of COVID are more infectious. Unfortunately, they're more deadly. Typically the influenza kills people every year when it comes through, mostly in the winters, and the death rate is around 0.1%, which is only 1 in 1,000. But if you're one of the ones, it's a big deal, obviously, right? Well, coronavirus is at least 5 times more deadly on the average, probably a little more than that, and way more than that in some high-risk groups. So COVID is much more, it's more infectious, it's more deadly. It's novel. This variant is novel, meaning that none of us, even us old people, who've seen many different flu seasons and survived, and many different colds in the past and survived, and often you'll have partial immunity to a flu you saw 10 years ago, and you may have the flu, but you're less likely to die from it because you have partial immunity. Well, unfortunately, this variant of COVID-19 came around, and it was so novel that none of the people, old or young, had any autoimmunity to it. That's been a big feature, and like number 3 of the 5 big things. The 4th of the 5 big things is that, unfortunately, and we didn't know this in May, we were hoping, but we were hoping it would be seasonal like flu, and we'd get a respite during the warm months. And unfortunately, this coronavirus spread was not substantially reduced by heat, which does seem to attenuate influenza. So it was not seasonal, and that's been a big problem. The seasonal factors are worse in the winter, though, when we're all cooped up and get closer to each other. But in terms of the virus being seasonal like influenza, unfortunately, it was not. We were hoping, but that did not bear out. And then the 5th thing, which is unlike influenza and makes this pandemic worse, is that COVID, this recent variant, is characterized by super spreading events, where it's very unusual. Influenza, on the average, a person with influenza will infect one or two other people, but in certain conditions, such as large gatherings, such as weddings or prisons or nursing homes, or large gatherings for whatever reason, bars, um, uh, you can have the virus spread to multiple people, as many as 80 from one person. That's been documented. And that kind of super spreading events have been a big part of why this has been very hard to fight, because it's hard to get rid of all of those kinds of events. And here we are, instead of in person, we're doing it on Zoom. And that's because we're trying to reduce the contact from human to human, as we well should, because I think we're going to be looking at this situation over the next 6 months. But as we get vaccines going, and we'll talk about that at length here in a minute, we should start to see the light at the end of the tunnel. It's very important. So what is it? How did it get here? Why is it a big deal? I kind of touched on that, but let me just give you a few recent statistics which should punctuate absolutely in your mind that this is not a hoax and this is a big deal. And here are the facts. If you think back, like I did growing up, worshiping some of my ancestors for having done fabulous things in helping humanity during World War II, and you think about how many American military deaths there were in the 4 years of World War II, it turns out there were 417,000 over the 4 years, which is horrendous. And we all have that frame of reference in our minds in terms of what is a big problem from a death rate standpoint. And that was about 286 military deaths per day on the average during World War II for Americans. And then another frame of reference is heart disease, which is the #1 killer until COVID came along this year. And 2,150 Americans on the average die a day from heart disease, which is obviously, as a cardiologist, is a big deal to me. I think along those lines a lot. Cancer in the United States kills around 1,660 people a day on the average, and it's the second largest killer of Americans on a daily basis. And yesterday, a dubious record was set in the United States for COVID deaths in one day, 4,300 deaths in one day. That's almost 20 times as many people that died a day during Americans that died during World War II. And it's more deaths than, if you add up all the heart disease kills today and all of the cancer deaths today, COVID is the #1 killer in the United States right now. So it's not a hoax. The pandemic is real. It's been getting worse because of extensive community spread. Unfortunately, a lot of the efforts to contain the virus have not taken hold, and our communities, some areas have been part of the problems themselves, unfortunately. So that's kind of, is it a big deal? The answer to me is fairly clear. It is a big deal. And unfortunately, as I look at this latest surge, particularly, in LA and some of the areas that it's coming back around in, it's a huge ongoing problem. What can we do to reduce the spread? Well, as painful as it is, social distancing, quarantine when needed, wearing masks and frequent hand washing, like you've heard ad nauseum, remain significant elements that can improve, not eradicate, but at least make better and reduce the risk of spread. And yet still in the United States today, only half of the people, half of Americans are wearing masks out in public. And I think around Sangamon, we have a better ratio than that, I would be happy to say. But because of travel, that does not keep us safe because of people coming and going. And there's still a lot of our ministries where we have, particularly in some of the southern areas where we have ministries, where the community is really still not bought into the concept of mitigation efforts. And those communities, we still have ministries in the South, Hillsborough, Breeze, Highland, Effingham, where we have still high amounts of community spread even today, in spite of the recent mitigation efforts by the state. And then Green Bay is still one of the toughest challenges we've had in terms of the per capita spread. Green Bay, HSHS, Green Bay's been about the worst area. The second worst on the average per capita is probably in the O'Fallon region. I think that's largely due to the fact that most of the people that live in O'Fallon, you may know, it's kind of a commuter population, and if many people work in St. Louis when they live in O'Fallon, and then if they are not living in St. Louis, at least one of the family members in that household commonly are. So since St. Louis has not been very vigorous in terms of Missouri in general, in terms of mitigation efforts, the community spread remains quite high, and that's been a very challenging problem for our colleagues, particularly in O'Fallon. I would relate this to you. We have a staffed bed capacity in O'Fallon, the brand new hospital, full to the gills, 130 beds. We can eke out, if we can get enough staff, to cover 140 beds. And yet last Monday, believe it or not, the hospital was full to the gills, 140, and we had 25 in the ER waiting for admissions, 25 people holding in the ER. And that's a horrendous situation, but it is what it is. And I'm happy to say our colleagues are continuing to do the best they can to take care of these surges. And everybody is growing quite fatigued of not just the topic, but the actual disease itself. And it's been really unlike anything else I've seen in my 40 years of medicine. I initially likened the situation, in references to, I was an intern during the first year of AIDS. And so that was a big deal to us at the time. And obviously, really clinical. That was a once in a generation kind of situation. One day in America, we didn't have AIDS. The next day, it was a gigantic, a substantial clinical problem. And actually, it's COVID-19 has dwarfed the AIDS situation. And as I look back in the past until this hit, I thought, wow, those were really kind of the dark ages of medicine. And now this year's had me jigger my thoughts about that. And let's see, who is at greatest risk? It is clear. The data is clear. The older you are, the more the risk you have of dying. Not necessarily higher risk of catching it, but if you catch it, your chances of dying are higher. People who, the first 2 to 2.5 months of the pandemic, I'm thinking back in March and April, when it was the first wave that we saw in our communities in Illinois and Wisconsin, the death rate, if you were admitted with severe COVID at that time, the death rate was 30%. 30% of the people that we admitted at that time died. That is horrendous death rate. For your and since we've had better treatments, we've had some improvement in treatments, we've had some improvement in protocols, and we were able to identify people more earlier and handle things better. Remarkable improvement and reduction in death rate in our hospitalized population in a very short period of time. I mean, really amazing medically. Because by the end of the summer, our death rate was down from 30% to 10%. Now, that is a huge improvement, but let me say, 10% of the people you admit to the hospital with COVID still die. It's 9.5 or 10% still now. That is still, what if I admit you to the hospital with a heart attack? Your chance of dying in the hands of a prairie physician is only 3% that admission. So COVID is still that much more likely to kill somebody who's sick enough to be admitted than with a heart attack. You'd rather have a heart attack than COVID if you're sick enough to be admitted. This fact is lost on a lot of people, and I have no idea why. It just boggles my mind. Now, there are a lot of people that get COVID and barely notice it, and that's been part of the super spreading problem, because some people can be infectious and not know it. Upwards of 35% of people, particularly the young, it's awesome that they die from COVID on a much lesser rate than the elderly. I mean, I'm glad for the young, but unfortunately, they're the arbiters of much of the spread that get to our older patients, and therein has lied a big part of the problem. Let's see, what are some of the newest treatments? We've got some antibody treatments. We're doing some of these at HSHS. We have had some new drugs. The old drug Decadron actually is effective when people are very critically ill and have a hyperimmune response. The proning with the better ventilator techniques has been a huge improvement over time. Bardoxolone, we were part at St. John's. We had, I think it was 7 or 8 patients enrolled in the Bardoxolone trial, which is an antiviral drug given by IV to critically ill patients in an effort to try to save them. And that was actually a phase 1 trial that our colleagues, hospitalists and intensivists, got involved in. We don't have enough long-term data to say how effective it is, but that goes to show you what can be done at the local, at St. John's when we rally our forces, and we can and have in the past been involved in early phase trials. And I've got to tell you, that's when your team is tired and starting to lose hope, one of the things that actually can help it with engagement has to do with the trials that we have going on. A lot of them run through a Prairie Education Research Cooperative, because we have the infrastructure to do clinical trials. And when you've got people who have such a high death rate, it is certainly reasonable in many cases to consider, what else can we do? And it's engaging for our colleagues to be involved in that, and you'll read more about that going forward. So we've done that at Summit HSHS. We've done some other novel things in O'Fallon. Takes an infrastructure to kind of do some of those novel clinical trials, but we do have that. We don't have that infrastructure so much in Wisconsin, but over time we'll build that. That will be part of the vision. Let's see. Now, coming up upon the topic of vaccines, and then I'll be quiet and answer questions. But what is going to stop this pandemic is either everybody getting it de novo and having autoimmunity, which actually probably 25 or 30% of Americans have already had it, whether they know it or not. We know the 12, 13, 14% have had it by positive PCR test or definite no. Those are those numbers you see on CNN. 30 million Americans have been positively identified. We know that there are many others that had it and maybe they thought it was a bad cold or they have relatively asymptomatic, and although they can spread it, they survived and they probably have autoimmunity. And so probably 25-ish, maybe 30% of Americans have already had it, so that the good news is that chances are most of them, unless they're immunosuppressed, are not going to get it again for at least, we're not certain, nine months, maybe longer. the big problem is that about 70% of Americans haven't gotten it yet. And so as bad as it's been, meaning the 370,000 Americans died in the last 11 months from COVID, as bad as that is, that represents, we have 70% of the nation that still hasn't had it yet. So you can do the math. The downside risk is huge. So the backstop to that has got to be the vaccination programs. I'm extraordinarily pleased with our colleagues and the immense amount of work they have done to put together the vaccination program that we have been doing the past 3.5 weeks to get our colleagues vaccinated so that they can make it to work, not on quarantine, not pass it along to patients, and not get it themselves, again. And the thing is, we have, unlike the average, I have to brag on our colleagues on this. In Illinois, of the vaccine doses that have been handed out to different hospitals across Illinois, including Chicago, only 30-some% have already been given. The rest are still in refrigerators due to the very challenging activities and operations that you have to do to get actual vaccines out of the refrigerator into arms. It's an emergency use authorization release, and we have a lot of hurdles regulatory wise, a lot more paperwork, a lot more consents, a lot more follow-up, and it's a 2-dose regimen. So the early vaccinations have gone slower than many would have liked, just because of the operational issues. We actually, although the rest of the state is averaging in the 30s, we're nearly 90% of the vaccines we've been given are already in arms at HSHS today. In fact, by Friday afternoon, we're going to be out. The other odd thing is that we don't know what vaccines are going to be shipped to us, believe it or not, next week. So operationally, this is a big lift, both on the federal and the state and the county level. Locally, we've got our teams are ready to go. We've done a pilot on some over 75-year-old patients with the remaining few vaccines that we had for this week, and then hopefully next week we can start. It will get allocations arrived, not promised arrived, but arrived, and then we'll start booking people to get the first dose who are patients, because we've taken care of all of our HSHS colleagues that wanted it, which is about 60% of them. There are about 25% of the colleagues, for one reason or the other, are vaccine reluctant. And the vaccine reluctance in the nation is about 50%. And it's I thought it would be 10% in our healthcare population, but it's actually about 25%. So over time, that will get better as people see that the side effects, while they are there, the side effects are certainly a lot less in aggregate than what one would get from catching the virus itself for the most part. And we've given over 12,000 first doses at HSHS, if you add up the doses given at all the different ministries. And at this point, we're out of vaccine in 7 of 9 ministries in Illinois. We still have some available in Wisconsin, and we're waiting for more. So we are ready for more, because it does nobody any good in the refrigerator or in a shipping container. So we're true believers in the vaccine theory in terms of stopping this pandemic. And we all want to get to the other side of this pandemic and get back to normal life and travel and see your parents and do all the things that we used to take for granted. And there've been a tremendous amount of learnings. The upside is that I do believe if we can get people vaccinated as quickly as possible, we can get herd immunity. I think it may be 6 months with a strong, robust vaccination program, but it could theoretically go a little quicker. I'm sanguine about the fact that it will probably take 6 months to see the end of this. So we can talk any specifics about vaccines that you would like. I know a lot about cardiology, and unfortunately, I know a lot about COVID and vaccines now the hard way, and other parts of medicine, largely I have forgotten. So are there any questions?
Yes.
Yes, so we had quite a few questions come through in the chat. We've got about 5 or 6, I believe. The first one is, will we have to get the vaccine every year?
It's a great question. Thank you for that. We don't know. Here's why we don't know. The vaccine trials started around in the July horizon for both Moderna and Pfizer. Those are the 2 currently approved vaccines in the United States. The Oxford vaccine is approved in England. We don't have that in the United States yet, so I won't specifically address that. It's a little different. The 2 vaccines that we have, the Pfizer and the Moderna vaccine, are mRNA vaccines. They started back in July. And so here we are, it's January. And so we know that in many cases back from July, they're still effective, 6 months later. But we don't have 12-month data, we don't have 18-month data. We will. It is possible and even potentially likely that it's a once a year booster injection after you get the first series of 2 vaccines. I would kind of anticipate that. It's also possible because some of the people have seemed to have really robust immune response, which may be more protective, and maybe even with some not just antibody response, but T-cell mediated immunity. And if that's the case, we may only need a booster every other year. But right this minute, unfortunately, nobody knows. Time will tell. They're following that data, and we will know certainly by fall. Good question.
Awesome. The next one we have is, when do you expect a return to normal gatherings and reduction of social distancing?
I would think the earliest will be about 6 months. I think I'm not a betting person, but the vaccine rollout is going slow enough in terms of will it be speeded up in 8 days? Maybe so. I would say 6 months. There's going to be a lot more people with disease in between now and 6 months, and unfortunately, herd immunity is the summation of people who've had it and have retained immunity plus number of people vaccinated. So we may get to herd immunity the hard way, meaning that like Sweden, they didn't do any mitigation efforts until last month when they just started to be overwhelmed with deaths, and they changed their mind. And it was a bad medical decision. It's easy to say that in retrospect, of course, but I think if we can get half the people vaccinated and 30–40% of the people have had the disease, then we could have herd immunity in 6 months.
Awesome. The next one is, can you compare and contrast the possible long-term effects of getting COVID-19 versus the possible side effects of the vaccine?
Well, from what we know already, they're really in the trials of 70,000 people with these first two mRNA vaccines. Nobody died. And, nobody's died over the course of 6 months that received the vaccines. There were very, very few, 0.6 significant reactions. Most of those were rashes. And the number of people that got disease and died in the trials was 0. So you have to compare then the theoretical potential long-term effects of an mRNA vaccine to the known long-term effects of getting COVID. And we know what the COVID effects are. 0.5% of the people die. You have a significant number of people with long-term issues that are now becoming more clear. And those are way worse than the theoretical risk from an mRNA vaccine. Now, when we talk about an mRNA vaccine, you're talking about something that gets injected and your body says, oh, that's something foreign, and raises an immune response, just like it would if you got a cold or something like that, or influenza. And then when the next time your body sees that kind of similar piece of mRNA from a COVID infection that you got from from your uncle or something, the immune response is quicker because it's already so it recognizes, oh, I've seen that and I know what to do with that. And so you get the immune response quicker and you don't get as sick, or the body fights it off enough that you don't even notice it. So that's how a vaccine works. Now, the good thing about an mRNA vaccine is there's no live attenuated virus vector in there, like some of the old vaccines that we used to use that did cause an occasional significant anaphylaxis. But the mRNA pieces are shorter. And they don't hang around in the body long term. In fact, the actual mRNA probably in most people is gone within 15 or 20 days. It gets metabolized. It's not retained. It's not like getting herpes simplex and then you get varicella shingles for off and on for the rest of your life. Where the virus is ingrained into your DNA. These vaccines or mRNA vaccines, they don't alter DNA. And that's what's so darned appealing about them and why they were able to be developed so quickly. They were developed originally 10 years ago in theory, plus then in practice to fight the Zika virus, which you will recall is spread by mosquitoes in the South. And when mothers would get that Zika virus, it was unfortunately associated with a very high number, as some viruses are, of substantial problems with the newborn. And these viruses were specifically developed against Zika, and they have one now for Zika. They just haven't had to use it because with the containment efforts of the mosquito, we haven't, knock on wood, seen the return of Zika here over the past couple of years, but it's on the shelf and ready to go should it come. That's why they were developed. The other reason they were developed, the mRNA vaccines, and I certainly hope this will pan out, is that they've developed pieces of mRNA to fight certain reactive pieces of cancer cells. Now think about this. If your body fought off and killed the cancer cells without chemo after you'd had a vaccine, how nice would that be? Well, those things are still under development. And I'm hoping that in our lifetime that will come to be the fact. So these are new for COVID because we didn't have a COVID problem until this variant came. And but on the shelf in the back, these other mRNA companies are working also on not just Zika, but Ebola, and also other viruses that may cause problems. Was a long-winded answer. I'm sorry. This is a really interesting topic to me. What
No,
other questions do you have?
that was interesting. We've got 2 more in the chat. The next one is, can you confirm that a person who has had COVID needs to wait 90 days to receive the vaccine?
It's a great question. The answer is that our feelings about that have changed, and this is why. People who have had COVID and recovered are very likely, almost certain, to have some autoimmunity, so that if they get it again, they're at least their body's at least gonna recognize it and fight it quicker than they did the first time. That's the good news. And we feel fairly sure that 90 days, that the normal people with normal immune systems, now this is not every person, but the people with normal immune systems are probably going to be immune for at least 90 days, if not 6 months or 9 months or a year. We don't know yet. We'll know. Give me 6 months and I'll give you a better answer based on data. The 90 days came out. So in terms of the risk, we have a shortage of supply of doses. And we want to give it to the people who are exposed the most and at highest risk. The people who've recovered from COVID are most likely protected for at least 90 days, if longer. So they were not triaged early high on the list of let's give our limited resource of doses to those people. So there was that issue. So the CDC last month came out and said, don't waste doses on people who've recovered for at least 90 days. That was one thing. The second thing was that there was some concern early, and this has turned out to be generally true, that the side effects of getting a dose of vaccine soon after having COVID, you might get a little more side effects from the vaccine because your immune system's still pretty revved up from the first go round. And that is probably true, but the thing is, the side effects of the vaccine in terms of sore arm, a little bit of a rash, or feeling fatigued, are more manageable than we thought on the average. So we've relaxed the requirement for somebody to have to wait 90 days after recovering for COVID in order to get the vaccine. In fact, we vaccinated several people like that. The third reason is that some of the people that got COVID in the first place may be relatively immune deficient. People who have low immune responses for other reasons, like they're on steroids, or they have cancer, or they have inborn immunologic defects of varying degrees. And since they have that and got COVID, they may or may not have a robust response to their autoimmune system may not be as robust, and they may get COVID again at a higher rate than people who have normal immune response. And so withholding it for 90 days in those people probably not a bad idea. And it was about two and a half weeks ago, Dr. Fauci came out and said, we look at those 3 factors, and if you've got enough doses, and if you're somebody in a high-risk group with a lot of exposures, it is okay to go ahead and give it as soon as somebody is totally recovered from COVID. You don't have to wait 90 days. So that was a new teaching based on logic. And that's what we've been doing for the past couple weeks. Some people if they're a particularly low risk exposure, let's say they're working at home and they've recovered and they have normal immune systems, probably we should give that dose to somebody that is at higher risk first, and get on the second go round the next wave of vaccinations when we have more doses. circle back and give those people the vaccines. Again, a long-winded answer, but it's a kind of a complicated question.
No, of course. We had one more question pop up, so we got two more left in the chat. The next one is, if you had COVID, but are not aware that you had it because of being asymptomatic or mild symptoms, but later test negative for antibodies, does that mean you are now able to get the virus again? I can repeat that.
Yes, you would be able to get the virus again. There's some suspicion that if you had very mild or no symptoms, that the second go round could be worse. I mean, we just don't really know. There wasn't enough testing in the earlier phases when we didn't have enough tests. So those are people. So the corollary of that and the thinking behind that question, I suspect, is that should I get a vaccine if I may or may not have had a very mild case of COVID or had it and didn't know it? And the answer is yeah, you should, particularly if you're in a high-risk group.
Sure, of course. All right, and the last question we have in the chat is, when do we expect to see the vaccine widely available to the community, such as, for example, those not in higher risk groups?
Well, it's a very good question, and I wish I knew. There's a call today with Illinois Department of Public Health and the county public health teams that are talking about next phase. And my expectation, the rumor is that it's a rumor, and you know what, you hear all kinds of things, but that we're hoping that the governor allows us to move to 1B lists next week rigorously. We've always had the ability to vaccinate 1B list people up until now if we had leftover doses, so as we not waste any. And we never wasted a single dose. They're too precious. But 1B is the new definition is anybody over 65, and then essential workers, and that's about 60 million Americans. So everybody that's not an essential worker and over 65 is going to have to theoretically wait until that 60 million people have gotten it. Now let's look at that another way. Let's say half of those people, half of those 60 million people want to get it. So that means 30 million people. I think we could get to 1 million doses a day here in the United States pretty quickly. I mean, there have been days when we did 1,000 at HSHS in Illinois a day. If you add up the 9 ministries, and 600-700 in Wisconsin between the 5 ministries. So we, if you project that, the nation could probably next week start vaccinating 1 million people a day. Now that's going to take a lot of work and operations and things like that. But we don't have those doses, right? We can only give the doses we have. And so how quickly they roll out the doses is going to depend on how quickly we can get to the, let's say, projected 30 million 1B people. And then after that, it'll go, I believe, to the general population. So in a perfect world, it could be 2 months, you know. But in the real world, I think it'll be a little longer.
Thank you very much. We've got 10 minutes left on the clock. If there's anybody who, verbally wants to ask one. Otherwise, Michelle, I see.
Yeah. Thank you, doctor. My husband has significant cancer, 72, and is one of those people that has such a auto problem. Should a person that age and with all the different problems, should he take the vaccine?
I would think that the answer is yes, and that I when that can happen is going to depend on how quickly we get doses.
Okay.
So the downside risk of the vaccine is so low, and the upside potential benefit is so high, particularly if you've got underlying disease issues that make you more prone to infection, and if you're over 55. So if you look at the data, the data would say yes, that would be a very good situation to think about getting the vaccine.
Thank you.
And I saw one more pop up in the chat. Do you anticipate any new normal changes in practices in healthcare as a result of COVID? For example, implementation of universal precautions after HIV, those kinds of things.
I think we're going to be, it's a good question. Yes, I think there'll be some kind of operational things that, there'll be more telehealth options. People will be a little more reluctant to come in to the hospital than they used to be for certain things that are kind of elective, for example. So I think we'll see more telehealth. I think we'll see more universal masking. I think we're going to continue universally masking at HSHS for the foreseen future. I mean, we may not be wearing N95s, on the COVID floors all the time in a year, but I can anticipate, and this is why. One of the things we've learned, to the question, is that these viruses can mutate and come back, and anything we can do to reduce their spread will be important. There will be another COVID-like situation in the future. Will it be 10 years? Will it be 15 years? Will it be 3 years? I don't know, but a lot of the lessons learned this time hopefully will be applied quicker before it becomes such an awful pandemic. And the one that I look to the horizon for and worry about is still Ebola. It's a horrible virus, and it could jump out of Africa again. And if it gets to the United States, if we don't jump on it quickly, it could become a pandemic. And so we have had lessons that we've learned dealing with the coronavirus that hopefully will keep us out of this amount of trouble in the future, but only time will tell. So we've not seen the last pandemic. Hopefully we've seen the worst pandemic in our lifetime. None of us have seen anything anywhere near like this, but there will be more in the future. I just can't predict them. Like I wish I could.
Yeah. I have one more quick question. I know several people personally. Actually, my youngest brother, who's very healthy in his 40s, lives in Manhattan, and he had COVID back in March, and he was not hospitalized, but he, was coughing up blood, desatting, burning lungs. And even to this day, just walking around sometimes, like he'll get a little short of breath. And then there are a couple of people that my son knows that are in their 20s that have similar things that, they went back to their workout routine, but they become short of breath, or they get a little burning in their lungs. I'm sure there's like follow-up studies, but do you foresee like a lot of long-term effects with the COVID infection, or is it too early to tell?
No, I think it's going to be spotty. I think that some people that had a bad immune overexuberant immune response to the virus, where the body overdoes it. The body goes to kill the virus and overdoes it and damages a lot of the normal lung tissue cells, right?
Mhm.
There will probably after that be some fibrosis of some of the lung tissue.
Mm.
And I suspect some of the people whose bodies reacted badly or to the virus may have some long-term effects. I suspect they'll follow under the headline of pulmonary fibrosis to varying degrees. And so, but that's certainly not all people who got COVID. Most people will recover and will not, once they've recovered, not think about it, and they'll feel back to normal. But some people do have prolonged effects. Unfortunately we know that now. Now there was no cure when they got it back in March, and there's no cure now, but we can attenuate those things better than we could in March. Those are people who might have benefited from earlier robust Decadron, or remdesivir, or bardoxolone, or something that like we're using now. The long-term studies will help answer that question, but in the cardiac arena, about a third of the hospitalized patients, the people with really bad COVID, those are people with really bad COVID, have some cardiac events of some sort. A lot of them have clotting, some have bleeding, some have arrhythmias, some have strokes. And so cardiac involvement is about a third of the time in the really sick people. Kidney involvement is common. So
I just would
does
think
not
that
surprise me. Some people, so if you've got, so it's going to depend on the amount of lung. If you're making I would view it kind of like this. Okay, if you're making blackberry jelly and you're putting the blackberries through the colander, along the way, as you're mushing down the blackberries to get the juice, right, the little tiny little seeds are stopping up some of the little holes in the colander, and a few of them slow down the flow of juice, but a lot of them make the juice totally stop. And lung disease is a little bit like that. You've got a certain amount of little lung alveolar sacs, and as some of those plug up from whatever reason or the others, if the other ones, you've got left over enough of them to still do the job, then you may not even notice it. But over time, you put enough miles on the tire, you're not going to wake up someday and have more tread.
Very true.
Right.
I would just think that some of that, I mean, for me personally, some of that potential long-term effects for somebody normally healthy, that in and of itself would be enough incentive to get an immunization.
It's a very emotional thing, unfortunately, and it's become politicized, and there's a lot of misinformation, and I mean, it's hard for me to look back and see how the heck did this happen, but it did.
Well, thank you very much.
Hey, Caitlin, can I ask a question? Will this be available in a recording that we can share on Facebook or with friends and family who have questions? I found it so perfect to answer so many things that I'm getting from friends and family in the community. I'd love to just be able to direct people to this.
Yes, I am recording it, and I'll be following up with each of you with an individual email, just a little bit more about the foundation and what we do here, and that will be included in it.
Thank you.
Thank you. Thank you all so much. Thank you, of course, to Dr. Shelton. This has been a vast amount of wonderful information. I know I learned a lot too. Definitely. So on this slide, you'll see my information as well as Bev Nizer, our Chief Development Officer's information. If you have any questions about the foundation or anything else coming down, feel free to reach out to us. The foundation website is listed as well. And thank you again, and have a wonderful rest of your day.
Thank you, guys.
Well, thank
Thanks.
you. Thank you, Dr. Shelton.
Thank you.
Dr.
Shelton. Hello? How do I get out of this?
Pretty interesting.
How do I get out?
I can close it out too, so that way it's done for everybody.
Good job. That was great. Great. Thanks everybody for
Oh,
participating.
yeah. That's so
Thank you,
informative.
Doctor.
Thanks.
Yeah, it was really great.
Thank you.
Thanks everybody.
Thank
Bye,
you.
guys.
Thank you. Bye-bye.
Bye.
Bye-bye.
Okay. Let's see.